Right. Good morning, everybody. Thank you for coming, and we will go ahead and start. It's an unscheduled grand round dedicated to World AIDS Day, and there are a couple of announcements I need to do right away. Is please ask, I'm asking everybody to turn their phones and pages on silent, and I also want to welcome and acknowledge our WebEx attendees, whoever has found the time to be in front of the screens. Thank you very much for attending. The way we will run the presentation today, I will do the talk, and then we will have two distinguished guests with us, panelists. One is really not a guest, more the host, Dr. Larry D'Angela, and Amanda Castell from George Washington University School of Public Health, who is a PI of DC cohort, very large study, and also very prominent and good collaborator for children in many directions. And we will talk and have a short panel on the topics of the pre-exposure and post-exposure prophylaxis. And just to start with, I'd like to acknowledge today the fact that we are on December 1st, and December 1st is a World AIDS Day. And just share with you a couple of the latest statistics globally. Overall, we're seeing an improvement in HIV world epidemic. We're seeing a decrease in new cases. We are seeing a significant drop in mother-to-child transmission of HIV. In fact, since 2009, 48% drop of transmitting the virus from mother to the child. And we're seeing very significant commitment, financial and global, to give the meds to the people. So out of estimated 36.9 million of people living with HIV in the world, which is about 37 million right now, 15.8 million have access to antiretroviral therapy. So this is half, approximately. We still have 2 million new infections each year, and we still lose 1.2 million people each year to the epidemic. So despite this good strides, there is still plenty to do. And I will talk today about a very interesting aspect of HIV, which is relevant to a lot of people who do not have infection, though I will mention an infected cohort of people as well. And this is pre-exposure and post-exposure prophylaxis. It's a really big change in the world of HIV when we no longer talk just about treating and saving life and saving people's life from AIDS, but we're talking about preventing HIV in people, and not only preventing mother-to-child transmission, but preventing from person-to-person in horizontal transmission as well. And I just want to say that for me as a pediatrician, this is a really wonderful reassurance of pediatrics being the field number one in medicine, because in the reality, the PMTCT, or prevention mother-to-child transmission of HIV, was the first modality where we started using drugs in for the purpose of preventing infection in an uninfected person. And that model actually expanded now to the adult field. So really very nice recognitions for all pediatricians in the room. So what I would like to do is today is pretty much define with us to recognize and discuss the risk of transmission. I think particularly working in a medical institution, we are very familiar with these issues, and what I will do, I will show you some call scenarios which our service, and I know occupational service by Larry and Kathy, gets periodically. So we will define with you what is a risk for acquiring HIV, what is PEP, very common terminology for people in the field of HIV, or post-exposure prophylaxis. We will define what is PrEP, or pre-exposure prophylaxis, and we will define some national, institutional, and regional approaches to this prophylaxis. So post-exposure prophylaxis, or PEP, if you attend any HIV meeting, that's what you're going to hear, PEP and PrEP. It's kind of child game a little bit, but PEP can be divided in two. It can be occupational, when you were exposed to HIV through your professional involvement, or it can be non-occupational, which is a life scenario for the majority of people who are exposed to HIV. So I wanted to start by giving you a few examples of the calls that can represent the quest for the post-exposure prophylaxis. Not all of the scenarios that I'll present dictate the need for post-exposure prophylaxis, but they raise the question, is there anything that can be done or needs to be done to prevent infection? And here you can see the examples. First one is outreach clinic call. The resident was draining an abscess from the leg of a 4-year-old boy and cut herself with the scalpel she used on the patient. So the question is, do we need to do something? Do we need to worry about HIV? We live in the area of HIV epidemic where in Washington, D.C., 2.4% of population are infected with HIV, and therefore, by World Health definition, we are working in the area of HIV epidemic. Second call, HIV clinic. Breastfeeding nurse was given a flu shot to a 17-year-old girl who is infected with HIV, and she stuck herself when discarding the needle after giving the shot to the patient. And occupational health calls, I know Larry and Kathy share a great deal of those. I actually got some in the middle of the night as well. There is a great sense of urgency in people, and sometimes the calls even don't route to the mechanisms that we have in. Nurse on the ward was trying to flush the G-tube of a 17-year-old girl with perinatal HIV and cerebral palsy. The fluid splashed back straight in the nurse's eye. And I can tell you I was exactly in this nurse situation through my career once. So how high is the risk? Can we run the study to assess the risk of transmitting the infection in healthcare workers? That study would be impossible to design. So all you can collect is observational data. And these are just some journal statements from the CDC, from MMRW publication from 2015. And by the way, you will see me giving you quite a few references in the recent years. The attention to PEP and PrEP has risen dramatically after several clinical trials where we've shown the efficacy. Therefore, you will see a lot of citations and a lot of national papers of national guidelines significance have come out since 2012. So the percutaneous exposure to HIV-infected blood is 0.3%. Mucous membrane exposure is 0.09%. As you can see, these numbers are not high. And non-intact skin exposures, when the skin has been abrased or cut, is less than 0.09%. These numbers are important to have because the normal reaction of personnel and staff is sense of panic, and no matter how good we educate our healthcare workers, we still lag behind in the knowledge in HIV. Just as an example, I was recently involved in Washington Hospital Center in a consultancy of the newborn who was suspected to be infected, and when I went to examine the child, the nurse approached me with a box of gloves, offering me to double glove myself. Just that fact of knowledge and perception of risk by the personnel still indicates even that the more healthcare workers who are well educated, who are licensed, still there is a sense of that stigma and that fear. So there was a really first nice publication in many years where the CDC looked at the data and looked across the hospitals on the confirmed cases of occupationally acquired HIV published in the same volume from January of this year. And as you can see, the total number of cases, and we're looking with you at the period from 1985 to 2012, so quite span of the years, total number of registered and reported cases of occupational HIV infection is only 58 cases in the duration of all these years. And when they try to break down and see who are the people who got infected, as you can see, the majority, not surprisingly by the occupational hazard, were nurses, then followed by lab technicians and clinicians, and only 10% were physicians who were non-surgical. So who are considered for occupational exposure, and this is not my definition, this is official CDC definition, all people listed on this slide, and I'm not going to bother you all reading through that, but all people listed on this slide are considered occupational exposure if they have come in contact with HIV infection throughout their professional involvement. And as you can see, it varies anywhere from the students and trainees, obviously emergency medical personnel, to contractual staff not employed by healthcare facility and persons who can affect patient care and potentially be exposed through other ways. So this is one of the major publications in recent years who has really changed our approach to the post-exposure prophylaxis, and this is what's published by U.S. Updated Healthcare Guidelines, and it's partly available. It's available through PubMed, and it is free for download. So what is now recommended in the U.S.? Post-exposure prophylaxis is recommended with occupational exposures. They are wonderful algorithms. I will not spend your time walking you through, but if any of you ever want to get the exact pocket algorithms, they are all very much available on AIDSinfo.nih.gov. So you can very easily Google and download the pocket card for any circumstances, which has very nicely designed algorithms. When the occupational exposure has taken place, HIV status of exposed source patients should be determined if possible to guide post-exposure prophylaxis. It is not obligatory, and medical system has no right to force the patient to test for HIV. So it depends on different states. Actually, legislation might vary a little bit, but in general, the rule of thumb is patient has to agree to be tested for HIV if there is no HIV test on the patient medical record. And post-exposure PrEP should be started as soon as possible, and that's one of the most frequent reasons for the call. Usually it's within first 72 hours, but the sooner the better. And the new recommendation for the U.S. is to continue post-exposure prophylaxis for the total duration of 4 weeks. That's pretty much the same as we did before, but now the recommendation very clearly states the use of 3 drugs. We have attempted using the 3 drugs in the past, and we not always were successful because the toxicity of the older generation antiretroviral meds is hard to tolerate. And it's very hard to take the drug that makes you nauseated when you need to continue going to work, or makes you have a quite significant diarrhea, or alters your sleep and creates a lot of dizziness to the point that you cannot drive the car. For that reason, there was a lot, and I know Larry experienced a lot of situations where patients selected to go on 2 drugs instead of 3, because the combination of these 3 drugs, in particular introduction of Calitra or efavirenz, made this side effect. However, now we are with you in the era where we have much better drugs to treat HIV, much more forgiving, much more efficient, and what's most important, much less toxic and much better tolerated by patients. And therefore, very strong recommendation on a national level to definitely use 3 drugs. They are more superior in reducing viral load, and I will talk in a minute about new classes. The concerns about patient drug resistance are commonly used ARVs. Who do we have in the hospital frequently with HIV? We have patients, in particular in old facilities, who are experienced, treatment-experienced patients. They might have virus that is baseline resistant. Introduction of only 2 drug prophylaxis might not be sufficient for the patient who is exposed to the patient who has himself, for the occupational exposure after the patient who has himself been on different regimens for over the years. And potential for improvement here is definitely because the new drugs have significantly less side effects. So dual and RTI backbones, and I apologize to those of you who are not familiar with the abbreviations for HIV drugs. They will take the whole slide to spell them, but this is nucleoside reverse transcriptase inhibitors. These are drugs like zidovudine that you might be familiar with, lamivudine, this abacavir or tenofovir. So the combination of these 2 drugs plus INSTI, the funny name is for integrase inhibitors, and this is the most promising new class drug for HIV. So 2 medications from the first class, an integrase inhibitor or boosted protease inhibitor or an NRTI. As you can see, your menu for what you can offer your patient and discuss with them has significantly increased. Other antiretroviral drug combinations may be indicated for special cases, as we discussed already, if the source patient is known to be highly resistant and none of the proposed drugs are working. You might consider doing 4 or 5 drug prophylaxis in occasional cases. Expert consultation is recommended, and I want to highlight we have a 24-hour hotline in the hospital that Larry has run for many years, and I believe shares now with Kathy Ferrar to some point, but there is also a national PEP hotline, and I must tell you the quality of that hotline is very good. It is run out of San Francisco, and it is a very strong group. And I myself was not one time in a situation where there was a very complicated scenario with an untreated hepatitis B co-infection, where the decisions really needed to be made on orthodox way, and discussing this was just a true pleasure experience because you do get a very high-level consultant on the other end of this line. So the recommended regimens, the most widely approved, is tenofovir and FTC or emtricitabine. That is 1 pill. Truvada is the 1 pill. It's 2 drugs co-formulated in 1 pill, fairly well tolerated, fairly decent size compared to many of our pills, some of which are very large size and difficult to swallow. It can be also used as tenofovir and 3-TC, which will be separate formulations, zidovudine and 3-TC, which is another combined in 1 pill formulation, and zidovudine and emtricitabine, 2 separate formulations, plus integrase inhibitor, or INSTI, I'm used to call it, raltegravir. But I will show you now some of the hospitals in the U.S., despite of this recommendation of using raltegravir, still consider doing another integrase inhibitor, dolutegravir, because it is administered once daily. And out of those drugs, Truvada and FTC can be given once daily. Tenofovir and S3TC can be given once daily, but zidovudine and S3TC, or so-called Combivir, will require twice daily administration, which, you know, with busy schedules with adults might become an issue. And that's the reason why some hospital centers in the U.S. have moved from recommended raltegravir to dolutegravir, because raltegravir requires twice daily administration. There are very few people who, because of occupational exposure, want to commit to 4 weeks of taking medications twice a day. So usually the first request we hear, can I have something that can be taken just once a day? And then boosted protease inhibitors are listed here. They are now co-formulated with cobicistat, couple of them, but we don't have yet studies that justify the use of those drugs with cobicistat. So the majority of them will involve taking patient 2 pills, except for Calitra. So again, pill burden, tolerability, patient acceptability, and ability to commit to 4 weeks of treatment, not really having symptoms and not really knowing always why am I doing that. If you for sure know that your source was HIV positive, that appears to be quite well justified. However, in many scenarios, decisions are made without knowing the source patient status, and then it becomes risk and benefit ratio, where physician and patient need to have mutual decision. And finally, we have now the medication like Stribild, where all the drugs are co-formulated in one pill. And I just want to give a warning after practicing HIV medicine for many years that do not count that because an adult person is an adult person that they can swallow a very large pill. In fact, a lot of adult people still struggle with the size of the pill. And when I say one pill once a day, it's wonderful, but I do want to point out it's a fairly good size pill. It's a size probably close to my phalanx of my finger. There are a couple of drugs that are not recommended for the post-exposure prophylaxis, but this is a pretty much the national approach that is replicated across the institutions in the country. So what needs to be done when you are evaluating occupational health? Close follow-up needs to be done. You cannot just see the patient, recommend something, and then let them go. You really need to give them a number where they can call with the side effects. You need to make sure and verify that they do have access to the pharmacy, and the pharmacy indeed has HIV meds. For suburban, wealthier Maryland area, I can tell you on one weekend I ended up calling 30 pharmacies before I could locate one that had the medications, because the incidence of infection is much lower. So you do need to work with your patient. Do not let them just go. Obviously, for occupational health, for our settings, it is very well taken care of because of our location. HIV testing at baseline needs to be done at 6 weeks, 12 weeks, and 6 months after exposure. We will talk in a minute about the possibly different scenarios. And then complete blood counts and renal and hepatic function tests are usually done at the baseline and 2 weeks after the exposure, because a lot of our medications depend on renal clearance, and they also involve the hepatic function in one way or another one. Now, I did mention that I will talk to you about the HIV testing being possibly different. And being possibly different is because nowadays we have a 4th-generation ELISA test, which also has an antigen in it, and it is able to detect infection as early as 2 weeks from the moment of acquiring the virus. The new national guidelines were published in the summer of 2014, and those guidelines virtually eliminate, so familiar to many of you, Western blot. So if we, in older generation, we need to do ELISA first, second, even 3rd generation still requires Western blot for confirmation of infection. The 4th generation antibody antigen combined test only requires NAS, nucleic acid tests, such as RNA or DNA, for the confirmation of infection, and eliminates Western blot. And therefore, in the settings where the 4th generation test is available, and I must say Joe Campos has been really upfront trying to introduce it at Children's. We have encountered our own difficulties, but it's been really a pleasure to work with our lab on that. But in the settings where the 4th generation test is available, the testing after the exposure does not need to wait 6 months. It can be fully completed 4 months after exposure. So you are giving patient 2 more, and in this case, patient or healthcare worker, 2 more months of easiness. You are able to clear his status 2 months or earlier. However, if you are working in the settings where there is no fourth-generation test, and this is now becoming a very familiar question. With any call, we're asking, the first question we're asking the providers is, what kind of test do you have? Because frequently you'll run into providers just an HIV test and they don't specify. You really need to know what kind of test is done, because if it is a second generation, not fourth generation test, you will need to repeat the screening of the exposed individual at 6 months after the exposure. So this is a non-occupational PEP or non-occupational post-exposure prophylaxis. And this is a little bit probably continental breakfast, daily cry and morning after pill, which is a common scenario for people start worrying, did I get myself into trouble? Was I exposed to somebody with HIV? And I think this particular becomes quite relevant in the light of the recent news that covered all the headlines. You all have seen this very famous actor, Charlie Sheen, announcing publicly his HIV status, and it was flooded internet very shortly in with all kind of speculations. With whom did he sleep? When did he sleep with them? Should he have told the people about his status? Should the people now worry? What is his viral load and his physician appearing with him in front of the cameras and making the case for that? So let's talk about this non-occupational exposure. So this is the table with the summarized risk factors, and they're very similar. This one particular I downloaded from the New York, but they have several databases where from multiple studies, depending on the jurisdiction, people have assembled those numbers. And you can see that this is the estimated risk, and it very much varies by the type of the exposure that the individual had. Needle sharing for the individuals who use drugs IV and share the needles, 0.7% roughly. Receptive anal intercourse for the MSM with an infected source, and actually also translates to female anal intercourse as well, because by some unpublished data, there is a high suspicion that we are not usually routinely asking female partners about anal course, but it actually does take place. We just don't have a real statistics. Maybe Larry and Amanda can shed some light on that in the comments. And then you can see that based on the type of the sexual encounter, the risks are different, and they are not the same. And obviously, we know the infection is mostly related among the MSM, and that correlates with the mechanism of transmission of HIV. And for oral sex, you can see down when there is not a full, when there is ejaculation has taken place, we still don't know what the risk actually is. It's perceived to be low. And it will very much affect how we talk to our young people about the forms of sex. And young people are asking these questions very, very upfront. So here's a couple of examples. What can you hear in a pediatric hospital of non-occupational post-exposure prophylaxis? 17-year-old boy is brought by his mother for evaluation. He told her he was at the private tattoo party, which apparently is quite fashionable now, and yesterday, and he has 2 new tattoos. And those tattoos were done. What happens is somebody brings the tattoo machine, and there's a lot of booze and a lot of fun, and then people just tattooing from one skin to another. Machine migrates, needles are not always changed. 18-year-old girl reports that she had sex with 3 boys last week and just heard that one of them is HIV positive. And one of the emergency department calls, 6-year-old boy was sexually abused by 14-year-old relative. That was a real scenario in our child abuse practice, and it's his own home. So the reality is, again, I'm not going to provide you all the answers. I can comment, for example, on the last case, on the last bullet, we could not test the 14-year-old because the parents refused, and he refused to be tested. So here's the scenario. You don't even know the source of the offender HIV status, but this suggests the scenarios that tend to arise in the pediatric practice. Another couple to share with you, 4-year-old boy, and this is quite common actually. It might raise eyebrows in some of you, but I've been called on that more than once. And I know Kathy too. Playing in the park, found a used condom that he tried to blow as a balloon. His 3-year-old sister stuck herself with a needle from used syringe found in the same location. 8-year-old boy referred by his primary care physician because there are multiple syringes found at home from visiting uncle who is using IV drugs every day, has hepatitis, and has HIV. But he didn't put it here, but in reality had all of that and quite advanced disease. And the boy might have been stuck himself. And then 6-week-old boy, it actually was an admission to children's and intensive care unit here with human bites all over his body by his mother, who is HIV positive and multiple drug resistances. So just a few scenarios to run through how complicated these issues can be. So non-professional post-exposure prophylaxis also went through the major national uplifting and the major national attention in recent year. This is publication in JAMA in 2014 that set up really the rules of how we are approaching non-professional post-exposure prophylaxis. And then another one you can see here was published by a really fantastic team of people, Ken Meyer from New York and Sasha Jane, Practical Guidelines for Non-Occupational Exposure. So these two publications slightly overlap, but put very nice emphasis on how to approach it. I just want to highlight that for children, not much has been done. And for children, we will talk down the line, but officially on CDC guideline, that's only available for children and AAP. And official CDC guidelines, if you ever Google guidelines for post-exposure prophylaxis on CDC, that's what you will come out. Please look at the year. It's 2005. So I do want to warn the audience, if you just pick CDC guidelines, that's what you will find. But you need to look at the wider, because the true guidelines have been updated, and they've been updated through major publications in elite journals. So the exposures here are quite obvious. For non-professional exposures, it is unprotected sex. It is all kind of body secretions. It can be protected sex where there was a condom failure. It is obviously intravenous drug use, and all of you are familiar with recent Iowa outbreak in the United States. Other mucosal and wound exposure, and exposures involving an insertive oral partner or human bites that usually do not require prophylaxis. And I want to highlight that because in the case that I described to you with a young infant, there was an excessive exposure and there was multiple broken skin. But for the majority of the simple human bites, they do not require prophylaxis unless there are extenuating circumstances, as in the case that I have shown you on the previous slide. So the most common prophylaxis is the same. The drugs act the same. It's the same virus. It's used in Truvada and raltegravir. And I do want to point out that Truvada is given once a day. Raltegravir is given twice a day. And this is a preferred regimen. And the reason why dolutegravir has not been pushed forward yet is just because we still don't have published studies on the efficacy of the dolutegravir in these circumstances. And dolutegravir represents the same family as raltegravir, except it's given once a day, and it's usually very well tolerated. But just because we have only the studies to date to prove to us that raltegravir is efficient, this is why this combination of once a day, one pill, and then another pill given twice a day is given currently. And new interactions with other medication, few interactions so you don't have much. And then one is really benefit, and those of us who work with integrase inhibitors know it is capable to bring viral load incredibly down with an incredible speed that we have never seen before. And this is one of the reasons why these drugs are now recommended for the post-prophylaxis. And just to share with you, this is the occupational and non-occupational. It's a combined algorithm that is used at the Boston Medical Center. And Ellen Cooper, a good friend and colleague who is a lead physician with infectious disease department there, shared it with me. As you can see, the Boston Hospital has stepped away from putting raltegravir exactly for the reason of tolerability and exactly for the reason of once-a-day therapy. And so you can see on the hospital-level guidelines, they are recommending using dolutegravir. I believe we still formally recommend raltegravir, Larry, right? You'll comment. So just to share with you that people are moving in this direction, even despite the lack of data. Yes?
Priscilla, are these recommendations the same for children as they are for adults? Have these drugs been tested?
Excellent question, Mark, and I'm moving on it right now. They're not, because we don't have really recommendations on children. And I will show you we are very behind there, though people start doing something, but not official on CDC level yet. So non-exposure prophylaxis can be discontinued if the source deems HIV negative. So this is very important. If you have any circumstances where you started the patient on it because you didn't know, but then you had a chance to test the source patient, you can stop the prophylaxis as soon as you have information on the source patient. If the source is HIV infected, is on treatment, you really need to know the resistance, as I pointed out, because it might affect your choices. And the source also should be tested for hepatitis B or C, or you have to test the patient if you cannot test the source. If there was a case of sexual assault or other circumstances that complicate the exposure, clearly you need to do empiric treatment for gonorrhea and chlamydia, and non-victims of sexual assault should be tested for all sexually transmitted disease. And if it is a female, the emergency contraception should be offered to all victims of the sexual assault. So going to Mark's very excellent point about how about children. This is the last formal publication by American Academy of Pediatrics, and I'm a member of the AAP Committee on Pediatric AIDS. We are pretty much now detained by CDC publishing the updated guidelines to publish ours. But the reality, Mark, is for kids, nothing has been published or specifically studied, neither for kids and, to the matter of fact, adolescents as well, since quite a time. So we are very behind there. So if you look at the formal recommendation for kids right now, you will find this. You will find a very outdated recommendation on zidovudine 3-TC plus lopinavir, ritonavir, or Calitra, which we all know has a very poor palatability and very poor tolerability. And very few kids actually finish the 4 weeks of treatment. There is national data indicating that the patients actually end up discontinuing frequently treatment because of tolerability. Adherence is a big challenge, and I can tell you that poor follow-up and rates in several pediatric studies, most of them published before 2010, show that people, in fact, never complete all 3 drugs. They drop Calitra and they continue to other drugs. And just to follow on your question, Mark, this is available now, and if you go to aidsinfo.gov, this is a pocket size, very nicely compounded, but it is not CDC endorsed, and it is not the AAP endorsed approach to using raltegravir. This particular handout developed by AETC, which is a very well repeatable source in HIV world, can be used, but again, not yet endorsed by AAP and not yet endorsed by the CDC. Let me move quickly to another topic, which is the pre-exposure prophylaxis. Pre-exposure prophylaxis is, we know of it quite long, and I already highlighted it's mother-to-child transmission. We've been doing it since mid-90s. Adults are actually learning from pediatricians in this case. Occupational pre-exposure prophylaxis is very rare, but it happens. When Haiti happened and a lot of our physicians were going overseas to work, we've got tons of calls asking to give them prescription for the drugs. They were not intentionally starting to take them, but they wanted to have drugs available for post-exposure prophylaxis. And I had only one call from somebody who said, can I just start taking the med because I'm very invasive, I'll be working a lot with the blood, I'd rather just to take pill every day. Unfortunately, I will warn you directly, most of the time insurances do not cover this cost, and the drugs are expensive. Non-occupational, on the rise. So taking drugs to have an unprotected sex with a potentially infected individual is on the rise in the U.S. and everywhere, and it's a completely new modality, and it's just been endorsed, and you will see the WHO HIV guidelines being released right now in December. It's being endorsed by World Health Organization. For the first time, we're going to say on the global level, give the drugs to negative people and protect them from getting an infection. So the ultimate PrEP is here. You can see this young man, not that young man probably, is preparing for the party. He's cooking, he has a nice bottle of wine, and he has an HIV test kit. Do all the people really do that before they get together for a nice, intimate, cozy evening? That would be your PrEP, because you would know your partner's status. And the reality, let me ask you, who has the right answer? The most effective PrEP is not to have sex. And when I give talks to the younger audiences, I won't challenge this audience, but I frequently will ask them, please raise the hand who has never had sex. And for some reason, nobody ever raises the hand. And then I usually turn this question back to them saying, but that means that every one of you is actually potentially positive. You need to be tested because sex is carrying this disease, and there is no guarantee. I tease my physician as well. I go to pretty nice fancy practice at Foxhall once a year for physical, and every year my doctor finishes my physical. I ask her, did you order HIV test for me? She says, Natalia, I know you, I know John. I said, you don't know me. I travel internationally. How do you know? So we always have a good laugh out of it, but I always tell her, you need to order the test. I live in the area of the epidemic. Why are you not testing me? So So PrEP for infected persons. Are we always talking about PrEP for only negative people? Not true. We also want our children who are infected, and this is our frequent message to our adolescents who grew up with the virus. We are telling them, protect yourself, because I can treat your virus, but you might acquire a virus that is resistant, and protect others. So PrEP is not only for negative in our view. PrEP is also for those who are positive. If you diagnose the person who just got infected right away at the time when his viral load is so high that he's most effective for his partners, you are doing PrEP for others because he's continuing having sex at the time of very high viral load. But if you are able to diagnose him early on and put him on treatment and tell him to abstain from sex for a couple of weeks until his viral load is down, you have protected a lot of people in the community from the virus. So I just want to enhance, I won't stop that much here, but supporting adherence. If you have a young individual who is questioning, getting tired of taking his meds, one of the reasons to tell him take meds is say, you enjoy having sex, right? You want to have more freedom of mind when you're having sex, not to worry that much if the condom gets ruptured or so with your partner. Take your meds well, because you will enjoy that part of your life more. You will be more at ease because your viral load will be controlled. When your viral load is controlled, you're much less infectious to your partner. Regular assessment of substance and sexual practices, individualized risk reduction, and provision of condoms. And Larry and our clinic are very well famous. And I really want to tell you, many of you might not know it, but we're the first, among the first pediatric hospitals in the nation that actually has, if you walk to both our emergency departments here at the CNMC, we have big fish bowls full of condoms. We are really one of the first pediatric hospitals really actively promoting, even at the level of emergency room, free distribution of condoms sponsored by Department of Health. So that's for those who are positive. So let's talk. Many of you might remember a couple of years ago we had the pleasure of hosting Dr. Myron Cohen here from University of Chapel Hill, North Carolina. I will not stop much of it because he gave the whole grand round on that study. But that study is very famous, and you might hear it even in the CNN news. Very famous HP1052 study. That was a breakthrough study that actually won the award of the scientific discovery of the world, of the year in the world. Then, because it was the first study that showed in 9 countries that treating early an infected patient significantly not only improved their disease, but it significantly reduced the infection acquisition by the partner. And it was a truly remarkable study because you can see a lot of couples, very large statistical power, 50% were infected partners were men. And what they did, they pretty much looked at the people, the diagnosed people with HIV, and then they chose to select starting early, or they chose to wait and see at which point immune system of an individual will go down. And I will not stop on the benefits of the patients, but protective effect for the partner was 96%. In fact, study was stopped early for that reason because the data was overwhelming that if you control the infection in an infected individual very early on, you significantly prevent that he spreads the infection to his or her partner. And you also have realized that we can use the same Truvada for that prevention. So finally, pre-exposure prophylaxis for the in United States has come up, CDC have come up with the new national guidelines at 2014. And by the way, all of the sources I'm showing, I can be very freely accepted and I very freely downloaded from the web. And the current approach to pre-exposure prophylaxis, again, for repeating, and I apologize for those who know this, but just to put it in your mind, it is for negative people. It is taking Truvada. It is combination of 300 milligram of tenofovir and 200 milligram of FTC, taken it daily. It requires daily administration to prevent them from acquiring an infection. Acute and chronic HIV infection must be excluded before PrEP. You need to test your patient. You cannot administer PrEP without knowing the patient's status, because if the patient is already infected with HIV, you are going to create a ton of resistances by treating him with only 2 drugs instead of 3. HIV infection should be assessed frequently. If the patient is taking PrEP, it's not indulgence. It's not a carte blanche to go on and have a crazy lifestyle. It is an agreement to work on the protection, but it should be mutual patient-provider relationship. And it is recommended that people who take PrEP get tested for HIV every 3 months. Again, you don't want to miss the moment if they get infected, because 2 drugs is not enough to treat. It's enough to prevent. and renal function needs to be assessed because tenofovir, we have now a new TAF just approved, and I'm happy to say Children's Hospital contributed to approval of the drug through clinical trial, which will be much less toxic for kidneys, and maybe then we don't need to assess renal function. But for now, renal function needs to be assessed. So who can you give this medicine? Persons at high risk for HIV based on background incidents or recent diagnosis of STI. So if I see an STI in a young man, I know that he's having sex unprotected because he acquired STI. So it's a difficult modality, and Amanda and Larry will comment, but it needs to be done with a great deal of judgment and a good judgment. When I mean judgment, not judging your patient, I mean good judgment of the risk factors, good evaluation of patient history, making this conversation comfortable for the patient to truly discuss what's going on with his life. And obviously some other risk factors are listed there. And these are the specific categories in the CDC guidelines. So it's sexually active MSM, as adult heterosexual active men and women who have substantial risk, adult injection drug use and heterosexually active men and women and partners are known to have HIV infection and considering conception of pregnancy. In fact, we are now with you at the air where the couple where one person is infected and another is not can conceive naturally without washing of the sperm, without doing anything else. All it requires is for an uninfected partner to go on the Truvada approximately 3 to 4 weeks before the couple is ready to transition for a non-protected sex for the person of conception and stay on this medicine until the couple is ready to go to use barrier protection back. So I will not stop that much because it's not much of the pediatric program, but obviously for HIV-infected drug users, it's crucially important. And there is the whole list of contingencies, what needs to be done and what kind of other provisions can help. And just to mark down to you, DC has just published a fantastic study, I know Amanda, you've been involved as well, really showing the benefit of needle exchange program in terms of preventing the HIV infection and real cost-efficiency benefits. So PrEP for adolescents, I know this is a common issue for us. It's a very common issue for Larry in his clinic. I just want to highlight, and it goes back to Mark's question, currently the data in adolescents are insufficient to recommend. So all we are doing, we are replicating adult data. And the behavioral and interventional factors and ability to work and have open dialogue about risk factors with the youth is crucial here. PrEP CDC guidelines really highlight that you cannot use tenofovir alone in all the circumstances because obviously some people have tried to reduce going from larger pill of 2 drugs to just using TDF, but not for MSM. And there have been some studies that suggest maybe 1 drug enough, but it is not the current recommendation to do that. The use of other antiretroviral medications in place of this is not recommended. So this question has come up more than once. Can I use something else? Currently, the approach is no. And the prescription of oral PrEP for the after the encounter, after sexual intercourse has taken place is not recommended. And it's also very frequent morning after mentality. Can I have a pill? I just had an unprotected sex yesterday. If you think your partner is very high risk, then we need to discuss the post-exposure prophylaxis with 3 drugs. Truvada in the form of PrEP is not an answer for post-exposure prophylaxis in this case. And just to finish up my presentation, we'll move to panelists, just another few examples of what we hear realistically in this hospital. 18 years old, perinatally infected young man who is MSM, man who has sex with men, with history of sustained non-adherence, profound immune suppression, very high viral load, untreated large perianal warts, so we know there's a physical factor to his infection, brings a partner of 2 years for discussing the PrEP. So he brings his partner, they have an unprotected sex, he's highly infectious, and he's bringing the partner to place his partner on treatment. 17 years old, perinatally infected woman with excellent control of her disease and undetectable viremia. An oral contraceptive presents with her HIV-negative boyfriend, and she wants to discuss with us because they are tired to use condoms and they want to have sex for some period of time without using condoms. A 19-year-old perinatally infected man with intermittent adherence and moderate degree of viremia tells you that his girlfriend and him decided to get pregnant together and they want to have a baby. So he's asking you, what can I do? How can we proceed from here? So just concluding the talk, we're moving the panel. What I want to highlight is these drugs. We talked about modality. We talked about situations, but truly the very good history is your best friend, as in many clinical diagnoses. We need to learn to talk to young people about that. Not comfortable for all the pediatricians, but these are the real issues that need to be discussed. Evaluating risk factors in non-judgmental method, let the young people really tell you what they think is crucial. I frequently will tell young people that I know about sex better and more than any of their friends at school. And I really want them to engage in a discussion with me, which is, I think, not true, but at least I'm lying and winning their heart. Individualized approach is very important. PEP and PrEP both require close follow-up. So none of the modalities we discussed is just give a prescriptions and send patient home. They're requiring really engaging with the patient. And recurrent PEP and PrEP both need to include counseling and risk reduction in all population. Not only talk to the patient or the healthcare worker who has done and is in front of you, but talk about everybody else who's involved. And just to finish, and I invite the panel, PEP and PrEP in real life. Since the news broke up with Charlie Sheen, we heard both. We're here and should have told people in advance and should have taken meds. And I was disturbed by this too because I think she looks like a teenager. But anyhow, so we don't have even dating teenagers as we highlighted. Or should the people who have had sex with him have taken meds right away after? You can see how life all these issues are. So I hope we opened up this a little bit for discussion. I want to invite Amanda and Larry on the stage. We have a few minutes left so we can answer questions or share the perspective with you. Thank you.
Thanks, Michelle. This is obviously a very comprehensive overview of a very controversial topic. And I think that there are a variety of things that Natella's covered that are, however, there are other aspects of these, of PrEP in particular, that are now beginning to emerge as major issues. And first and foremost is the cost. You know, PrEP is very expensive. Right now, it's estimated that it costs somewhere between $6,000 and $10,000 a year in order to provide pre-exposure prophylaxis. That's because the drugs are still very expensive. But if you can sort of project that over a population base of individuals who might be at risk, you're talking about some real money. I just reviewed a paper for a very prominent adult journal specifically on the cost effectiveness of treating injection drug users, uninfected injection drug users with PrEP. And the 20-year estimated cost for just national guidelines for treating injection drug users. The 20-year cost is $44 billion with a B dollars. So, you know, we're really going to have to confront how the healthcare system is going to be able to incorporate these kinds of costs in terms of protecting individuals from HIV infection. In fact, the quality-adjusted life years of disease-free status, the projected cost for one quality life year is $253,000. So, as I said, this is a dramatic cost. Yeah.
I did two comments regarding that. One is that cost is similar to what the cost is for treatment of rare diseases, for which there are about $300,000 a year. So it's already being done. My second is a question to you, which is, Natella sort of suggested that this may not be paid for by insurance or not completely paid for. Is that the case
for the ones that you're talking about? Because obviously people aren't going to do it, aren't going to be incentivized to do it if they're going to have to pay $6,000 to $10,000 a year, may not be able to.
Yeah. Luckily, most of the Medicaid programs, at least in the District of Columbia, are paying. And a couple of the private insurers that I've dealt with for some of our patients are also paying. The other thing that I do want to mention, right, that's right, and the other thing that I do want to mention is that in individuals who've been using PrEP in Australia, there is now a new major epidemic of syphilis again. And if you think about it, what you're looking at are individuals who now feel that they don't need to use the same level of protection any longer. And so I think that we have to look down the line as to see what we're going to accomplish. And I think that Natella's point was actually, tremendously important. That the most important thing that we're going to be able to do, if we're going to prevent infection, is to be able to convince people that they need to protect themselves at the highest levels possible.
Sure. I was just going to add that there are a couple of other issues, I think, even before you get people on PrEP, which is that we have all of this data from these clinical trials, but we really haven't been able to fully translate that data into the real-world context. So we've seen that there are people who were in these studies who were followed for, months and years, and it was a very intensive follow-up period. But when you get into the real-world context and people have life and nobody's really monitoring to make sure that they take their medications, I think that we really have to see if that efficacy translates into effectiveness. Also, and then just to add on to the Australia study, there was also a study that came out, a PrEP demonstration study that's going on in Miami, D.C., and in San Francisco. And the San Francisco data found that although they had no new HIV infections, they had huge numbers of sexually transmitted infections among the population in San Francisco that was taking PrEP, despite the fact that people had not increased the number of partners that they were having. They said that they had not changed the level of condom use, et cetera. So I think that it's definitely a cautionary tale.
First of all, I wanted to say it's kind of interesting because I'd like to know how much it costs per year to treat a person for their drug addiction. But the other thing I wanted to say was, Natella, you were saying about that tenofovir alone is not, so what if the partner actually has 184V mutation, and so the amitriptyline in the Truvada wouldn't work anyway?
It's a very good question. Kim is asking about the potential resistance to amitriptyline and whether the individual with resistance is having unprotected sex with an infected individual, whether then in Truvada, though you have two drugs, but actually only one becomes fully active. Well, as you know, we use 3TC holding regimen a lot, so I still believe it will have some effect on the decreased viral fitness. So that's to the moment right now. And as I showed, I didn't want to go because of time restriction, but there is some efficacy of the studies except for MSM. There is some efficacy of single tenofovir to date. But you highlight another important point, that it should be really a relationship. PrEP should not be, and I want to go back to Larry's comment, I don't see PrEP personally as somebody going on it lifelong and just living that. It should be really in a complex with the risk reduction. It should be viewed as a temporary measure. We will not be able to afford it, I think, lifelong in anybody, any society. And now the WHO formally is coming out with the guidelines that are going to be published this month, which will say for the global arena to use PrEP. It's really going to become a big challenger to the cost issue. I think there will be huge push for making generics and bringing the cost down for that. But as both Larry and Amanda highlighted, there's still a lot of unanswered questions. But one thing I can tell you, the study at CROI, one of them showed that even not daily adherence, these patients still did quite well. So we know that there is still a lot of unanswered issues because they realistically look at people not taking it every day, as we really instruct them to do, and still saw some protective effects. So I think as it becomes a modality, wider used in the areas, it will be, we will know more about it. Yes, Mary.
Natella, how long does it take to get the HIV test back, say, for an occupational exposure? And do you wait till that comes back before you start prophylactic treatment?
Excellent question, Mary. I'll let Larry answer. For occupational surgery, we have now the rapid ELISA test, just antibody test, returns back, and what we do in emergency room in 20 minutes. There is one rapid fourth-generation test that has been approved, but there have been some difficulties introducing it in the real practice, and I know Joe struggled with that.
So we're currently using a third-generation test, which gives you a higher sensitivity for antibody, but doesn't show you the presence of antigen. It takes about an hour to 2 hours. Usually when I get a call sometime after midnight, by 2 a.m., I'm usually able to make a final decision.
But it doesn't cover acute infection. So if an individual who is a source is an acute infection, he might have negative antibody test, and then you're in a real limbo because then you need PCR. And PCR, even in our institution, takes 4 or 5 days, depending on how lucky you are. If you have it on Thursday, you'll have it the same day because they batch them. But the reality is PCR test notoriously takes 4 or 5 days. So if you are stuck in a situation where you have tested individual with first through third generation, you will have more time to keep the patient on prophylaxis. If you have a fourth generation, you will know within a short time you can stop them.
Natalia, I wanted to ask Amanda a question because she has particular expertise in looking at the large population of HIV-infected individuals in the district and also their potential partners. But what's the level of acceptance of PrEP been citywide?
So we actually partnered with Children's Hospital, with the Adolescent Clinic, with Whitman Walker Health, Metro TeenAIDS, the DC Department of Health Southeast STD Clinic, back in 2013 to look at the level of awareness and potential uptake of PrEP. Knowing that we had such a high rate of HIV here in the city, we thought that this would be a promising intervention to really scale up here. And in general, overall, we looked at, we interviewed and surveyed about 300 people. Only 10% of them had ever heard of PrEP at the time. And this was about a year after the FDA approval. And it was pretty striking that people really didn't know about PrEP. But not only did they not know about PrEP, but PEP, which Natalia highlighted, has been around since 2005, was also about 10% of knowledge. So there's still a lot of education that needs to take place around PrEP and PEP. When we asked people if they were, we kind of then described it a little bit more to them, and about 60% of people said, oh, okay, now I understand it. It's something that if I talk to my provider about it, I might be willing to use it, considering the side effect profile, et cetera. And then when we asked about clinical trials, there were large numbers of people who were interested in possibly learning more about this prevention intervention. So promising.
Idea of whether okay, if we're talking about discordant couples that are pretty much monogamous or are monogamous, quote unquote, and the partner is, the infected partner is undetectable, is PrEP like going to give them that much of a is PrEP going to give the other partner that much of a difference in, would it be worth giving them PrEP because the other partner,
yes.
Yeah.
And the yes is because even though you may have an undetectable viral load, particularly if you're an infected man, doesn't mean that you have an undetectable viral load in your semen.
Right.
Unfortunately, it's a different compartment.
Just one more comment, Ken. A detectable viral load doesn't mean there's everyday undetectable viral load.
Right.
So if there was a dose miss, for example, you can have very mild viremia of like 60, 80 copies. And we really don't know very well whether this 60, 80 copies, the risk still. So to completely bring the risk to zero, but you're making a very good point. If the patient is undetectable, in fact, a few years ago, there was a very large lawsuit in Geneva that gained a lot of publicity in Europe that was lost. It was a woman who has had the sex with unprotected sex for quite a while with a man who was positive, who never disclosed to her. And then she learned of his status. She actually launched a very large-scale lawsuit against him, and she lost. because he was undetectable consistently by his physician's record. She did not get infection. She was suing him for the risk and damage, and she lost a very, very high publicity lawsuit because it was deemed that her risks was very, very low. So it's a good point to raise, but to bring it totally to zero, if you're in a circumstance of zero, yes, you will still recommend PrEP, but you're right to say that if the partner who is infected is undetectable, the chances of second partner are much, much lower.
And I imagine it would have gone a different way if she had actually become infected.
If she actually became infected, yes, she probably would have won.
I only have one last comment, and that is when we started the Youth Pride Clinic here at Children's for LGBTQ youth this past July, one of the real reasons that we started the clinic was so that people would know that we would be willing and encouraging to prescribe PrEP to individuals who might be at risk of HIV infection. And we've had an interesting experience because we've only had about a 50% uptake in patients that we've offered PrEP to. And in fact, in two cases, we've inadvertently ended up outing two of our patients because family members found the medication at home and asked why they were on that medication. So we still have a bit to learn about using PrEP successfully in our patient population.
And I just want to add that I think you all as providers, or we as providers, have a responsibility to really, just like Natalia was saying, her doctor thinks she's not at risk. How does your doctor know that you're not at risk? And so we have a responsibility to educate not only the providers, but also the patients as well. One of the most difficult things about anything related to HIV is understanding, are you at risk? And if people don't see themselves at risk or their providers don't see themselves at risk, then they're not going to get tested. They're not going to have access to prevention interventions like PrEP. And for those people who are unfortunately maybe going undiagnosed and HIV positive, they also won't benefit from treatment as well. So I think that's really where it all has to start, is risk awareness and assessment, and then HIV testing.
And just to highlight, if you pull DC statistics and our new cases, it's close to 26% other. That means there is no established risk factor. It's already new cases. It's documented HIV infection. And when we collect the data on a city level, try to identify, is it MSM, is it a positive partner? In 26, I believe, latest statistics, 20, so close to 30%, we don't know actually how the individual acquired it, because on the medical record, on the record that went to Department of Health, and Amanda can correct me, she works there, there is no identified mechanism of infection, which just highlights the point of really having an open dialogue with the patient on the subject, because we shy away from that frequently. Well, I guess I want to thank Amanda for coming from TW, and thank you, Larry, and thank you all for coming. And please, if you have a chance today, wear a red ribbon. And there are a lot of activities going on through the hospital, so you might see our team around. Thanks, everybody. Thank you, people on the WebEx.